Do you know what's new for nurses? What about dementia and caregiving? Are you looking to grow as a leader? And what are the current healthcare leaders doing for you? Welcome to the Angie Graham Podcast. Ladies, if the man you love is over 50, or if you're a man over 50, this conversation matters. You always need to pay attention to your health, but your prostate health needs to be high on that list. Prostate cancer is one of those topics too many men avoid until it becomes serious. Today, I'm talking with Dr. Clifford Gluck about what women need to know so we can help the men in our lives pay attention earlier, ask better questions, and take action sooner. Hi, I'm Angie Graham, and today our guest is my friend, Dr. Clifford Gluck. He is a board-certified urologist with more than 30 years in private practice. He trained at Stanford and UCLA and is all about improving our health outcomes. Dr. Gluck, thank you for joining us again on this important conversation.
Thank you, Angie.
So let's get right to the beginning here. What is PSA and where did it come from? And how is it actually measuring biologically?
PSA stands for prostate-specific antigen. So when I was a resident in the 1980s at the Harvard program, we didn't have PSA. We depended on our finger to find prostate cancers, and that's not the most sensitive way to find prostate cancer because most prostate cancer develops before any symptoms appear. So if we had a blood test that we could follow that might lead us to that diagnosis, it would be a huge advantage. What we did had was something called acid phosphatase, which was sort of a blunt instrument. In very advanced prostate cancers, acid phosphatase would rise. So we could follow it if we were needing to treat somebody. Luckily, some brilliant scientists in upper New York State discovered prostate-specific antigen and developed a lab test so that we could follow this. PSA is actually an enzyme that's produced by the prostate. It's a member of an enzyme family called kallikrein, and only the prostate produces this enzyme, so it's very specific to the prostate. When it was first discovered, they looked at a whole large population of men to see what normal would look like, and they picked 4 as the normal value. But there really is no normal value of a PSA. Every man has his own PSA. Some men have a uniquely low PSA, and some men just have a high PSA but don't have cancer. So it's really more about following PSA from year to year, PSA kinetics, to find out what their PSA actually means. So PSA is a blood marker. It's a blood test that every man should have done year to year in order to compare that PSA with the previous years to see if there is an abnormal change.
So what you're saying is they set their own standard by getting this test regularly. You can see then what their normal is, I'm assuming, because you say it can be different for each man. So you can then track if there's changes drastically in that, up or down. What would be the warning if you were looking at that?
Right.
What would be the indicator? Is it up or down or both?
Well, it's up. Up is bad.
Okay.
And a PSA that goes down is generally good. So every man's PSA number is unique to them. I call it like their sleep number. Everybody has their own number. And if your PSA, say, is 4, and you go back to the doctor and the next year your PSA is 5, that's a warning. The PSA should not rise more than 0.75 every year. If it does, then that warrants further investigation.
Okay. Why did the PSA screening become so widespread in the 1990s? And what impact did it initially have on prostate cancer mortality?
It's a great question because PSA screening saved a lot of lives. We used to have screenings where men could come for free as a community service to see a urologist, get a blood test, have a rectal exam, and see if there was something that was abnormal on that. And we picked up a lot of prostate cancers that way, men who were able to be diagnosed early and then treated before that prostate cancer spread and couldn't be removed. So the effect of PSA screening was to identify a large number of men in the population who had early prostate cancers, the kind of cancers that are good for cure and not for just watching and waiting necessarily. And we can talk more about what that means later on. But the biggest effect was that a lot of lives were saved and a lot of men were picked up with their cancer before it became very advanced.
Okay. So then it appears that then things changed. And what did the U.S. Preventative Services Task Force actually recommend? And why did they discourage routine PSA screening?
We have these wonderful government agencies that are made up of people that may not necessarily know or be experts in their field, but they come to a consensus to look at things based on some epidemiologic data and exactly the kind of things that they want to look at. Maybe they're looking at economic data. Maybe they're looking at other things. In years past, the government has recommended things as crazy as everybody should be smoking cigarettes. And the reason behind it was, well, we won't have to pay so much Social Security because people will die earlier. And that's true. So, I'm always a little bit suspicious about these government recommendations. The U.S. Preventative Task Force gave PSA a D or a D minus rating, stating that we were picking up too many prostate cancers, and because men had undergone curative treatment for it, these men had suffered side effects that were worse than the disease of having prostate cancer. That was the reason behind that D minus rating. Now, naturally, associations such as the American Urologic Association put up quite a fuss about that. They strongly disagreed and said, no, PSA is a remarkable and strong tool, and we need to use it in the correct way, and we should have conversations with our patients. We call it shared decision making, so that we decide what's best for each individual patient. But let's not generalize and say, hey, throw out the baby with the bathwater here. This is a good test. Let's keep it. So eventually, the U.S. Preventative Task Force actually revised their recommendation to a C rating, which was better than a D minus, but still not where I think it should be, is an A rating. It should be something that all men should be having from year to year. We don't have anything as powerful as yearly PSAs, although we do have other tests that help us refine our interpretation of a PSA value and help us to pick out more prostate cancers or exclude more prostate cancers so that men don't have to undergo further testing. So
We're Talking About It is brought to you by Our House Senior Living. Visit us at ourhouseseniorliving.com. I can't help but to think that when we talk about government regulators, always in the back of my mind, I'm very suspicious of what role insurance companies play in that as well. So my question to you that I have in my mind right now is, do insurance companies pay for annual PSA testing today, or did they back then?
At first they didn't, and then they started to. And yes, they pay for PSA today. PSA tests cost somewhere between $50 and $70, I think.
Okay, so not terribly expensive.
No. But saving a life is terribly valuable. I don't think we can put a price on that. So yeah, it's not like a crazy drug that they're spending tens of thousands of dollars on. No, this is a simple, fairly inexpensive test that can really save a man's life and also save his function, because the earlier prostate cancer is picked up, the less side effects a man is likely to have from the treatment for it.
Very important. So what were the consequences of backing away from the PSA screening over the past decade?
Well, once the bad recommendation came out, doctors felt that they no longer had to draw PSA. So men weren't getting regularly checked up on each year at their physical. In fact, doctors stopped doing rectal exams. That used to be a mandatory part of the physical exam, is to check the prostate, check the rectum. Actually, a lot of rectal cancers are within the reach of a finger. So a rectal exam is super valuable, not only for the prostate, but for the rectum itself.
Okay.
Well, not doing that kind of screening, we saw a large jump, about a 40% increase over the past 10 years in men presenting with late stage prostate cancer. These are prostate cancers that should have been picked up 10 years ago, but because nobody was checking, they were all missed. And now we lost our chance to cure them.
Wow. So we are seeing more men with advanced and incurable prostate cancer. And what does that data show us now?
Well, it shows us that a lot of men are going through suffering because the treatment for advanced prostate cancer is very different than the treatment for early prostate cancer. If your cancer is already spread outside of the prostate itself, usually to lymph nodes, adjacent organs, or the bones, then the only real treatment is going to be something we call androgen deprivation therapy. Androgen deprivation therapy means starving the prostate cancer cells from testosterone, the male hormone. It's actually not the male hormone, it's a hormone which is found in both men and women. But prostate cancer cells utilize testosterone. Prostate cells utilize testosterone to grow. And people used to have the misconception that taking testosterone caused prostate cancer. Now, that's not true at all. But for about the last 70 years, that was the feeling. And it all dated back to the work of a Nobel Prize winning urologist named Huggins, who in the 1940s did some experiments. First, he did some experiments on animals and then people, and found that if you remove the testicles from a man with prostate cancer, the prostate cancer would shrink. He measured it with the acid phosphatase, the thing I talked about at the very beginning of the program. They didn't have PSA back then.
Okay.
And then he found out that in one man, and this is really about only one patient, he gave testosterone back to the patient. And the prostate cancer, the acid phosphatase went up again. In other words, the prostate cancer got worse again. And from that one patient, they made the erroneous assumption that testosterone caused prostate cancer, but it doesn't. That was just an observation. And you can't make a conclusion from an observation or an association. So the reason it went back up was for a very different reason, in that it was starved first of testosterone, then you gave testosterone back, and then some of the cells grew back. That does happen. But if you have a normal man who has no prostate cancer, you can give them testosterone, it will not cause prostate cancer. And interestingly, what does cause prostate cancer is too little testosterone.
Really?
So we now know there was proposed a couple of decades ago something called the saturation theory of the prostate. And that said that there are a certain number of androgen receptors. These are the little receptors on the cells that testosterone attaches to. And at about a level of 250 nanograms per milliliter, this is the saturation level of the prostate for testosterone. So if a man gets testosterone and he's at 250 or above, the prostate's going to be saturated. Although the rest of the body wouldn't be as saturated, the rest of the body can continue to take higher levels of testosterone. And that's why a level of 250 or 300 may be normal for the prostate, but may not be normal for the brain or the skeletal muscle or the rest of the body, because almost all of our organs and integument have testosterone receptors on there, or androgen receptors, as we call them. If you have a lower level than 250, then your prostate is not fully saturated, and that puts you more at risk for forming prostate cancer. That's been shown in a number of studies. So it's healthy for men to have a normal testosterone, at least above the saturation level.
Okay. Can men have, and I'm just asking this question because I'm a woman and I'm trying to just wrap my brain around all of this. And I'm sure some of the listeners feel the same way. Can men have too high of testosterone levels? Is that a thing where they overproduce testosterone as well as worrying about low levels of testosterone?
Well, everybody has their own normal testosterone number, just like their own PSA number.
PSA number, okay.
So some men feel great at a testosterone of 300, and other men feel lousy at a testosterone of 800. They may need 1,000 or 1,100 or 1,500. But really, if you're treating men for hypogonadism, a low testosterone, you treat for symptoms, not necessarily the number.
Okay. So that's another one of the, everybody's got their own number, and you just need to know your number. So
you don't even have to know your number. You just have to know your symptoms.
Okay. So what would be some of those symptoms?
Now we're going to a totally different discussion, but that's okay.
That's how my brain goes sometimes, doctor. I'm so sorry.
But the symptoms of hypogonadism are fatigue, weight gain, brain fog, trouble concentrating, difficulty with hot and cold. Some people have night sweats. They actually soak the sheets because they have low testosterone. It's kind of like it's a symptom similar to menopause. I
was going to say, I feel like we've talked about this before, but it was menopause.
And now we call it andropause because that's what happens to men as they age. They do lose not only the amount of testosterone, but also the activity of the testosterone receptor. And that's why some men, as they age, may need higher levels of testosterone to actually get the benefit. So,
very interesting. And I can tell this will be a whole nother episode again. So where are we today, and what is the right way to screen men for prostate cancer in 2026?
Every man over 50, or if you have a family history of prostate cancer, or you have African American ancestry, or African ancestry, let's say, Black men, you need to start screening at age 40. If there's a genetic component of family history, start screening at age 40, and otherwise start screening at age 50. That's the recommendation. It's a yearly rectal exam and a yearly PSA, and the PSA should be followed to see if it rises more than 0.75. That's a red flag for doing an investigation to see if there's prostate cancer. And that investigation might include an MRI of the prostate to look at it and a biopsy of the prostate. And the biopsy is where a lot of people stumble and they say, wait a minute, too many complications from biopsy, risk of sepsis, risk of discomfort, risk of erectile dysfunction. Well, the truth is the risk of infection after prostate biopsy is 2%. The risk of erectile dysfunction is extremely low. That's almost unheard of. It's very, very low with prostate biopsy. Yes, there may be some cases of that, but that's not the way the nerves of erection run. They run outside the prostate, so it shouldn't be hitting those nerves of erection. It shouldn't be impacting them at all. So I guess the cases of erectile dysfunction after prostate biopsy probably need to be debunked and look and see if it really was an injury or if it's something else that's going on, something physiologic, something cortical. There are lots of reasons to have erectile dysfunction. So prostate biopsy is the definitive workup to find out if a man has or hasn't prostate cancer. And it's helped immensely by MRI. MRI picks up 80% of prostate cancers. It can visualize them. Now, conversely, MRI misses 20% of prostate cancer. So if somebody has a negative MRI, you can't say, hey, look, I don't have prostate cancer. No, you have a 1 in 5 chance still to have prostate cancer there. And I find it all the time. Men with a negative MRI, and they're loaded with prostate cancer, just missed it. So it's not a guarantee.
Okay. So those that are at highest risk and should be screened more aggressively would be?
Men of color and
Okay.
people with a family history of prostate cancer. That would be a father, a grandfather, a brother,
And they
or
would
an
start
uncle.
at 40?
Start at 40, yeah.
Wow. Important information for the wives out there, for their dads, their brothers, their loved ones. If a man has an elevated PSA today, what is the modern diagnostic pathway and how do MRI and targeted biopsies change the game?
We just talked a little bit about that, but MRIs will help to target where the cancer is in the prostate. 80% of the time, the MRI will find a lesion on the prostate that should be targeted. And then prostate biopsy is done using ultrasound. So the ultrasound can fuse that image to the MRI image, pointing out where those targets are and make it more directed. Some people think that you can just target what you see and then forget about the rest of the prostate. That's a wrong assumption. Clearly, multiple studies have shown that you have to do both the targeted biopsy plus a sampling of the prostate through 12 areas of the prostate. We divide the prostate up into kind of a grid and sample 12 areas. So there would be 12 biopsies plus biopsying any region of interest that we see on the MRI.
Okay. What could be some of the symptoms that a man is having that may indicate that there's something going on with the prostate?
Well, early on, no symptoms. There is
That's the scary part. No symptoms
right.
at all early. Okay.
That's why screening is so important, because you can't feel it, you can't taste it, you can't see it. I'm working with some MIT scientists right now on an olfactory method to detect prostate cancer, early prostate cancer in the urine. So we know we can train dogs to sniff urine and find prostate cancer. And
really,
the MIT scientists have developed a machine to do the same thing, and it may be more sensitive than a dog, actually, and easier to feed. So this machine can detect very early prostate cancer in a very simple way, a simple test, which might be more reliable. It looks more reliable than a PSA. PSA is one test. It's a point on a line. It has to be followed. But this may be a test where we actually say, is there or is there not cancer? And that would be a huge leap in an advance and help to save men from some unnecessary procedures.
Very fascinating. If unfortunately someone isn't getting screened, what are the symptoms that show up in the late stages?
For those unfortunates, it may be back pain because the prostate cancer metastasized to the spine, which is fairly common. Could be weight loss. Could be severe urinary symptoms like obstructive urination, slow stream frequency and urgency of urination, waking up a lot at night. Of course, those are also the symptoms of benign prostate enlargement, so it gets confusing. So when I say there really aren't definitive symptoms early on, it's true. There's nothing
just get your routine exams and don't mess around and wait for a big problem later, right?
All the women who love their man or relative should be demanding to see their PSA number, and also make sure that they had, when they went to their physical exam, that they had a rectal exam. There's so many
Okay.
doctors who are evasive now and say it's not necessary. They should demand it.
Important information. Um, let's see. So let's talk treatment. How do options differ from low risk, intermediate risk, and high risk prostate cancer?
For the low risk people, there's something called active surveillance. So if a tumor has what we call a Gleason grade of 3 or so, or even an early 4, then maybe you can follow that man along. The problem with active surveillance is it's always a roll of the dice. So I always explain this to men. Active surveillance was developed in order to avoid the complications of surgery and radiation. It never included other modalities, which really don't have the same percentage of bad complications. So active surveillance literally means follow you along, but don't treat your cancer. And when we look at some large studies from Scandinavia, we found out that a large number of men, about 2/3 within 5 years, had to undergo treatment because their disease was advancing. And unfortunately, at the time of treatment, a significant number of those men already had metastatic disease. So active surveillance is a roll of the dice. If you're old and sick and have a low-grade prostate cancer, maybe it's better to follow it. But if you're young and healthy, chances are you're going to develop worse prostate cancer in your lifetime. And when you find prostate cancer, that's the best time to cure it because you never know when it's going to advance.
Okay.
So other treatments, you asked me a big question, but other treatments for prostate cancer would include surgery, radiation, and something called HIFU. Those are all approved treatments. Then there's some investigational treatments, which we probably could mention, but we shouldn't focus on them too much. Surgery means removing the whole prostate. It's a radical operation. It is associated with a lot of healing, a catheter placement. When the catheter is removed, all men are incontinent. They leak. They have to wear a pad, usually from 3 weeks to 3 months or so, but sometimes it's up to a year. And even at 1 year, about 15% of men are still leaking and they'll never regain control over their urine. So they may have to have a further surgery, such as an artificial sphincter placement. That's the worst thing about surgery. The other bad thing is erectile dysfunction. Is somewhere between a 50 and a 70% incidence of erectile dysfunction, even sparing the nerves of erection. And one of the difficult things about surgery and nerve sparing surgery is that you can't see the nerves at surgery. We know where they are, we think. We try to avoid them without cutting across the cancer, but it's really, there's nothing clearly there to demarcate it, to tell you that. And it depends on the skill of the surgeon and a lot of luck in order to preserve those nerves. If you do radiation, you're going to radiate the whole area of the prostate, and you always radiate the nerves. So slowly over time, most men develop erectile dysfunction after radiation. And about 8% of men develop incontinence after radiation. But 8% of men also develop a second cancer, usually a bladder cancer, from the radiation. So there are risks in those procedures. In HIFU, which is high intensity focused ultrasound, we use benign ultrasound energy, the same kind of energy we use to look at babies in utero. If you focus that energy, just like the way you can focus the rays of the sun with a magnifying glass, you can precisely burn tissue without affecting other tissue around it. You can safely preserve any of the organs nearby and just treat something even down to a millimeter or two. And you actually can visualize the nerves of erection during HIFU because you can see them on ultrasound. You know where the neurovascular bundles are. So it's a huge advantage. You can precisely destroy prostate cancer and leave behind all the things that you want to leave: the nerves of erection, the urinary sphincter, and the bladder neck.
Very interesting. So this would be the better treatment of what we heard if you had this as an option.
Well,
Correct?
In a recent study, a multi-center study done in France called the HiFi study, this is kind of a seminal study, very well done, comparing HIFU to radical prostatectomy. And the conclusion of the study is that basically they have the same cure rate. They have the same treatment rate. But they don't have the same side effect rate. HIFU had very minimal side effects compared to surgery, a very low rate of incontinence, somewhere between 1% and 5%, versus 15% or more for surgery. And HIFU also had an excellent rate of preserving erectile function compared with surgery. So in a 2-hour outpatient procedure where a man can get back to his regular life the next day, he could have his prostate cancer cured. And, when most men are presented with those options, what do you think they choose?
That would be the invasive procedure, correct?
The least invasive, the
Least
minimally invasive. Yes.
I'm sure they picked that one because no man, no offense to the men out there, but they're not very good patients most of the time. And being laid up can be very difficult for both men and the women in their lives, right?
Nobody wants to be sick.
When they're used
That's
to that
right.
active lifestyle.
Yeah. Nobody wants to be sick.
I have learned so much. And when we finished up our last episode, you had said this is a topic that would save lives. And I thought to myself, wow, I don't know anything about this topic. And I'm so glad that you're absolutely right. It really impressed upon me the importance of it for the many men in my life that are over 50, my brothers, my spouse, and people that I know. It just gave me a huge awareness of how important this topic is. And I think it's difficult for men to talk about and they don't want to think about it. So I'm sure they try to avoid this. And now they've got the women in their life now in their ear on this topic, just tuning into this episode. So really important stuff. Dr. Gluck, thank you for sharing your expertise with us today. And to our audience, advocate for your health. Ask the right questions and do not ignore what your body has been telling you. Speaking up early can make all the difference. And if you know someone in your life and they need to hear this episode, please share. Sharing is caring. And as always, thank you to our healthcare heroes. I'm Angie Graham, and I'll see you next time. For more of the Angie Graham Podcast, check out our YouTube channel or our website, theangiegrahampodcast.buzzsprout.com.